Hello, everyone, and welcome back to another insightful episode of MedSynapse podcast series. And today we are diving into a topic that often receives less attention but also plays a crucial role in reproductive health, which is male infertility. With lifestyle factors, environmental influences, and evolving diagnostic tools, the landscape of male infertility is rapidly changing. And to guide us through this important discussion, I have with me Dr. Sujoy Dasgupta, a consultant in reproductive medicine and accomplished statistician, gynecologist, and infertility specialist. Doctor has had a stellar academic career with numerous gold medals and awards. He has authored several research articles in reputed journals and is actively involved in medical education and international conferences. His special interests include male infertility, recurrent miscarriages, and sexual dysfunction in infertility. Doctor, it's such a privilege to have you alongside me before this crucial topic.
Thank you so much for your kind introduction and thank you for inviting me today.
So, Doctor, to begin with, what are the most common causes of male infertility that you encounter in your practice? And have you observed any recent shifts in etiological patterns due to lifestyle or environmental factors?
Many times we don't find out a cause. We call it idiopathic. Maybe in such cases, lifestyle factors may play a role. Because nowadays we see the incidence of male infertility is rising. Maybe because of various factors, particularly our lifestyle factors like sedentary lifestyle, particularly addiction to mobile and laptops. We tend to use most time on screen. And we all know that sperm production requires temperature of scrotum at least 2 to 3 degrees Celsius less than the body, which is why the scrotum is situated outside the body. But if the temperature of scrotum increases, like by prolonged sitting, prolonged driving, smoking, increased body weight, and also if you are used to keeping your mobile in near your lap, and also when you walk with your laptop, keeping it in your lap, it increases the scrotal temperature. Also, at the same time, there are some men who are going to gym and they are taking testosterone supplementation. People they wonder why testosterone supplementation is so much detrimental, because testosterone, if is given from outside the body, it can't reach the testicle. Rather, it suppresses the sperm production. Having said that, there are some medical issues for which male infertility may increase. Number one issue is the pituitary gland problem, a small gland that is located inside the pituitary in the brain, that is called pituitary gland, and it can be affected by various tumors, some hormonal problems, and also some congenital disorders like Kallman syndrome. Secondly, it may be because of problem inside the testicle. Number one reason may be varicocele, or it may be undescended testicles, which may be operated or may not be operated, previous chemotherapy, cancer treatment, and also we see lots of cases of mumps orchitis and previous tuberculosis and sexually transmitted infections. Thirdly, there are many men who are having enough sperm production, but sperm is not getting out of the body because of some obstruction. It may be congenital, like congenital bilateral absent vas deferens, which is not very uncommon. At least in my practice, I've seen a number of cases. It may be because of some operation or some infection, which may cause obstruction. So there are number of causes that can account for male infertility.
Correct, okay. I think that is such a important perspective, also especially environment and lifestyle changes are also increasing. So it's very important perspective to consider. So, Doctor, building on this, like the diagnostic aspects also, how has the role of advanced semen analysis, sperms, the DNA fragmentation tests, and newer biomarkers evolved in the assessment of male infertility?
Okay. First of all, we should keep one thing in mind, that male infertility is very difficult to understand. We often see men with very low sperm count, they conceive naturally, whereas men with absolutely normal sperm count, their partners can't conceive. If we see the WHO, the basic semen analysis guideline published by WHO, what they did, they analyzed the semen analysis reports of various men who became father within 1 year of intercourse. Remember, they used the concept of percentile. So even the man with 5 million sperm count, he became father within 1 year of intercourse. Therefore, abnormal semen analysis does not mean infertility, whereas normal semen analysis does not establish the fertility. Therefore, advanced semen analysis testing, this also has the limitations. Like sperm DNA fragmentations, because many labs are advocating the test, we see number of prescriptions where sperm DNA fragmentation is advised. But we don't know exactly what to do if the sperm DNA fragmentation comes as abnormal, because we have seen many times when we are spending some time on doing investigations, the partner of that affected male with abnormal DNA fragmentation conceives natural. Therefore, always this abnormal DNA fragmentation does not require treatment. And remember, sometimes the oocyte can repair the damaged DNA of the sperm. Again, we don't know whether the actual treatment of sperm DNA fragmentation. And another problem is the lab technology, because the laboratory techniques for testing for this sperm DNA fragmentation testing is not yet standardized. Therefore, sperm DNA fragmentation should not be advised randomly. Rather, there are some selective indications like recurrent pregnancy loss, like recurrent implantation failure. Only in those cases, sperm DNA fragmentation should be advised. Similarly, other advanced testing for male infertility, that should be limited to only special situations, should not be advised routinely.
Correct. Absolutely. And I think the evolution also has increased also, and I think it has enhanced our diagnostic process also. So now, doctor, when it comes to treatment, one area that has always generated debate is varicose cell repair. So, based on the latest evidence, how do you decide which patients will truly benefit from surgical intervention?
I think this is the most important question and mostly asked question.
Correct.
So remember, first of all, presence of varicocele does not mean that it causes infertility. For example, few months ago, I encountered a man with grade 3 varicocele, but I did not advise surgery. Why? Because this man already received chemotherapy which suppressed his spermatogenesis. Therefore, in that case, the culprit is not varicocele, rather the culprit is chemotherapy. Therefore, we have to see the overall picture. Secondly, diagnosis of varicocele is important. Many times, we see that patients are advised ultrasound, scrotal ultrasound to detect varicocele. Remember, if varicocele is not seen clinically, but it is seen only by ultrasound, this is called subclinical varicocele that should not be treated. On the other hand, clinical varicocele can be grade 1, 2 or 3. It is the grade 3 varicocele that is visible without performing valsalva. Again, I repeat, visible without performing valsalva, that can be treated, but provided there are some other factors that should be taken into account. For example, there is no other infertility factors in the couple. Female factor is absolutely okay, because the aim of varicocele surgery is to help the man conceive naturally. Suppose if the female's age is 38 and her AMH is 0.5, no matter how good your varicocele surgery is, the couple will not conceive naturally. Secondly, this varicocele should cause abnormal sperm parameters, and also it causes testicular atrophy and sometimes playing in the testicle. In that cases, the varicocele can be repaired. Having said that, there are some evidences that varicocele surgery can reduce the level of ERT. Like instead of ICSI, we can do IVF, or instead of IVF, we can do IUI. But it should be done selectively, in judicious manner, and please check the man clinically in standing position and see whether the varicocele is of grade 3. Only in that case, advise varicocele surgery, provided that other parameters are satisfied. And please don't advise scrotal ultrasound just to diagnose varicocele.
Mm-hmm. I think that's very well explained, doctor, and it actually also highlights the importance of patient selection and evidence-based decisions also, that really matters.
Right.
So that's another area where I can think of where many clinicians seek clarity is the role of hormones. So what is the current role of hormonal evaluation and treatment in idiopathic male infertility? And are there any promising pharmacological approaches under investigation?
First of all, we need to categorize male infertility into mild and severe. Severe, of course, it includes azoospermia, but how we can differentiate between mild and severe? There are some papers which suggested that it should be differentiated on the basis of something called TMSC, total motile sperm count. That is the multiplication of total semen volume into sperm concentration into total motility. Usually, if TMSC is less than 5, we call it severe, and if it is more than 5, we call it mild. In mild cases, usually no investigation is required. You can repeat the semen analysis after 3 months. But in severe cases, definitely you need investigations. It needs hormonal investigations and, of course, genetic evaluation as well. Now, what hormonal investigations are required? Of course, the most important one is FSH. But at the same time, we tend to evaluate other hormones, testosterone, LH, estradiol, and also blood sugar. But in contrast to common perception, prolactin and TSH should not be done routinely. This should be done only when clinically indicated or when you suspect hypogonadotrophic hypogonadism. Now, regarding treatment, we know that for number of years, only area where hormone treatment works, it works like a magic, is hypogonadotrophic hypogonadism. You need to give a hormone supplementation, usually HCG. If it doesn't work after 3 months, you can add FSH. But you need patience because sometimes the spermatogenesis may require 6 months to even 24 months time to become normal. But the prognosis is good and they usually don't require air. Even in azoospermia cases, if you give hormone therapy in hypo, they can become biological further. Until recently, we had idea that in other cases, particularly in idiopathic cases, as we have mentioned, hormone therapy doesn't work. There is only one solution, that is ICSI. But there are number of papers published recently which suggested that even in idiopathic cases, hormone therapy can work. And to add to this, I must mention an interesting article published in Reproductive Medicine Online called Aphrodite Criteria, published in 2024. I'll request my colleagues to go through this paper. They actually categorize male infertility in 5 groups based on semen analysis, FSH, and testosterone level. They suggested that, for example, in female, in all cases, we can stimulate the ovaries with gonadotropin. Similarly, in male cases, why shouldn't we stimulate the testicles with gonadotropin? They suggested that in some cases, FSH work, in some cases, the HCG. But there are some evidences that this hormone therapy works better when FSH is not within normal range rather than when it is elevated. But again, there are evidences that even when FSH is elevated, hormone therapy, particularly HCG, can work well. And if you search in the literature, in 2024 December, our group published a review article in Asian Journal of Andrology. The title was Medical Treatment Prior to Micro-TC. We suggested that in most cases, hormone therapy should be tried. Apart from gonadotropin, you should check testosterone to estradiol ratio. If it is less than 10, you can try aromatase inhibitors like letrozole. But if it is more than 10, but yet testosterone is low, you can try clomiphene. At the same time, sometimes we see that these patients with male infertility, they frequently change their doctors, and all the doctors are advising antioxidants one after another. Remember, antioxidants per se are not harmful. This may be beneficial, although we don't know to what extent they are having beneficial role or not. But in severe male factor infertility, it has been found that if you don't treat them aggressively, over the period of 6 months, 25% of them can land up in azoospermia. Therefore, if you tend to rely heavily on antioxidants, you are actually harming the patients because the patients will land up in azoospermia. Therefore, you can give antioxidants, but it needs proper explanation to the patients that antioxidants have limitations. Rather, we can try hormonal treatment. And of course, if the couple can't afford IUI or ICSI at the present moment, we should consider freezing the semen because the parameters can worsen further.
Yes, Karthik, that's very fascinating to know. And then after moving from diagnostic and pharmacological to assisted reproduction, so how do you approach decision making between IUI, IVF, and ICSI cases of male factor in fertility, especially, considering cost effectiveness and success rate in different scenarios?
This is very important question because the decision making makes a huge role in male infertility. First of all, we need to take into account the female factors, the age of the female and her ovarian reserve. If there is severe male factor problem like sperm param is the total motile sperm count less than 5 million, it requires ICSI. There is no confusion about it. But if they can't afford ICSI, in that case, we can consider IUI with donor sperm. After explanation, that simple explanation. One option is that IUI at donor sperm, the success rate is low, but the cost is low. On the other hand, with ICSI, the success rate is high, but cost is also high, but it also confers the benefit of becoming biological father. If number two, if the sperm count is less than 5, total motile sperm count is more than 5, you can do IUI, provided that the female factors are okay, but you should not try more than 3 to 4 cycles of IUI. In that case, you should go for ICSI. So one parameter is TMSC, total motile sperm. But sometimes TMSC may be the borderline range, say 4 or 5 million, and the men request that, doctor, I can't afford ICSI as of now. Maybe I'll try ICSI after 3 months, 4 months. Question is, should we refuse IUI using his own sperm? The answer is no. Because there is a concept called double ejaculate. In that case, we can request the man, please give sample consecutively. That is, within 1 hour, please give 2 samples if possible. Because the concept of what we have been taught in our undergraduate days have changed. We no longer advise the men to remain in abstinence for 3 to 4 days before IUI, because we advise to have frequent sex, because it has been found that the frequent ejaculation improves the sperm parameter, which is why double ejaculate often improves the sperm parameters. And we often see that on the day of IUI, the first sample is horrible, but second sample is better. And we sometimes achieve pregnancy when we did IUI with second sample. So we can try something called double ejaculate. And also, what we can try is something called IMSC, inseminating motile sperm count. That is, we should check the post-OA sperm count. If it is more than 1, we can do further IUI. If it is less than 1, you should not do IUI. You should go for ICSI. Next is ICSI. Of course, if it is less than 5, ideally you should go for IVF or ICSI. But we tend to be more on the ICSI side. That is, we are a little bit biased towards ICSI because the chance of fertilization failure is less. And if it is the severe male factor problem, we cannot do conventional IVF. On the other hand, if it is azoospermia, in that case, we should check if it is non-obstructive, we should check karyotype and Y chromosome microdeletion, because there is only one contraindication to surgical sperm retrieval in non-obstructive cases, that is Y chromosome microdeletion A and B, that is AZF A and B microdeletion. Otherwise, we can try testicular sperm extraction or aspiration, or whenever facility exists, we can try micro-TC with ICSI. If it is obstructive azoospermia, in that case, if it is because of congenital bilateral absent vas deferens, we should check for cystic fibrosis mutation. If it is not there, we can go for PESA or MESA, that is percutaneous epididymal or microsurgical epididymal sperm aspiration. If that fails, then case out TC. Therefore, IUI or IVF or ICSI depends on female parameters and particularly the total motile sperm count.
Yeah, I think that's a very pragmatic way also to look at the treatment, and actually balancing science with patient realities is also really important to make this decision, Doctor. Doctor, finally, to wrap up our discussion, what are the major research gaps in male infertility that need urgent attention to improve both diagnosis and treatment outcomes for patients?
First of all, I must say, I think this was said by one of the researchers in University of Sheffield, that ICSI actually killed the research on andrology, because we can bypass male factor problems rather than treating male factor problems, which is why the research has not focused much on male infertility treatment. Rather, it focused on ICSI, that is bypassing the male factor problem. So firstly, we should have more research on what is actually meant by male infertility, why the sperm parameter varies, and why we don't still have the answer to differentiate between male infertility and male fertility based on semen analysis. Secondly, there are research gaps regarding the role of advanced diagnostic tests like oxidative stress testing, like this sperm DNA fragmentation testing, these things. Thirdly, hormonal therapy may play a huge role and it can avoid ICSI. Fortunately, after the product criteria came, we tried to apply in our clinical practice. In some cases, when the couple was ready for ICSI, but they conceived naturally after starting hormone therapy. So hormone therapy may have potential role and it's showing promising results, but we need more evidences, we need more research on potential role of hormone therapy, and also some other causes like why male infertility is increasing, like role of environmental factors and epigenetics that should be explored.
Yeah. Thank you for sharing that, doctor. And as we wrap up today's session, it's been an absolute pleasure, discussing male infertility with you today. And I'm sure that our audience of healthcare professionals will also, find your insights extremely valuable in their practice. So thank you for sharing that today.
Thank you so much. Thank you. Thanks.
And to our audiences, remember, if you're a healthcare professional is eager to delve deeper into medical topics or have questions, do not hesitate to join us on the MedSynapse platform. MedSynapse platform is not just a resource, it's a dynamic space where you can connect with your medical peers, participate in meaningful discussions, and contribute to the ongoing evolution of healthcare. So until next time, stay aware and stay updated.